Hello, good evening, everybody. Welcome to the third Prevent Caries Symposium. This session, the topic of this session is what should be the strategy of preventive dentistry in the pandemic time. I am Professor Esra Yıldız from University of Istanbul, Department of Restorative Dentistry. Today we have three valuable speakers from different countries. I want to introduce the first speaker. She is a Turkish one, but she is coming from America. And Dr. Sibel Dinçer is the clinical assistant professor in the Division of Biomedical Sciences at the University of South California. Welcome. And her topic title is Caries Prevention, Biological Basis and Clinical Implications. Please, Dr. Dinçer, we are waiting for you.
Thank you for your kind introduction. It's very nice to be back with everyone. Let me start my sharing. Please. So, today I will be presenting on caries prevention and mostly biological basis and clinical implications of caries prevention. So to introduce myself, I present from the West Coast today. So we're having some lag time with the slide sequence. I apologize. So this is a technical surprise for me. So as you can see, and as Dr. Yıldız kindly presented, I teach dentistry for University of South California, which is in Los Angeles, US. So excited to be with you today because I know dental students are in the audience, and this is a special day for me because my teachers whom I learned about caries from, they are also in the audience. And wrapping up the presentation was like a time travel for me because our view on oral health and caries risk management has changed so much for the last 20 years since I have graduated. And as well, some of the critical purposes of this summit here was to chase and question what should be the strategy in preventive dentistry in pandemic time. And based on CDC work and releases, we know that it is evident that populations that are disproportionately affected by coronavirus disease are also at risk, higher risk for oral diseases. And so they have some things in common, and those people that are at risk, they now have limited care, limited access to oral care and dental offices. So since April 1st last year and April 16 last year, ADA has announced that dental offices should be limiting their care to emergency care procedures. So now we are questioning the access to care for preventive and risk management purposes. So we know that there are some common factors in between those diseases, such as stress, poor diet, alcohol and tobacco use, substance misuse, and behavioral health issues, which are increasing in pandemic time as well, which is our worry. It will most possibly, and we're trying to prevent it, reflect on shifts in oral care and caries risk management. A lot of things has changed in practice of dentistry. A lot of things has changed in education of dentistry, and a lot of conversations about future of dentistry. That's why I said wrapping this up felt like a time travel for me, because these changes are going to impact our education. Has already impacted how we practice for the future in dentistry. And there is tremendous collaboration, and I think that's how it should be between medical profession and basic scientists and technologists and researchers, because that is what is going to bring us forward and is going to forward this conversation. I'm going to bring to our attention some fundamentals on the biological basis of oral health and disease. As an oral medicine specialist, what part of my purpose and my function at USC School of Dentistry is problem-based learning, teaching, and facilitation. So we teach problem-based and case-based format, because we care that we care about the fact, and then we think that our students should be learning biological basis of each disease first, and really distinguish the difference of understanding what actually is happening with all the elements, because that is fundamentally what is going to shape their perspective for their future practice. And whenever things are changing, they are going to own that critical thinking and that understanding, and they can navigate the shifts in their practice. So here, I'm going to touch upon some fundamental elements of the biological basis of oral health. So I'm going to be traveling between hats of biomedical sciences and dentistry and oral medicine as managing medically compromised patients. What is at the basis of oral health and disease? First of all, our understanding of oral microbiome, host microbiome interactions. The fact that we are constantly dancing in between symbiosis and dysbiosis when we talk about oral health and disease. For this, we shall and we should understand drivers of dysbiosis, because basically that is what we will be approaching when we talk about prevention, risk management, and treatment of diseases. First of all, to be able to prevent a disease, we have to be understanding very well each of those elements here to the bone. And we can only prevent something if we approach every single element here. And sometimes it's impossible. That's why we talk about risk management instead. So those terms, very interesting to emphasize them for students. What do we mean when we talk about treatment? What do we mean when we talk about management? And what do we mean when we talk about prevention versus risk management? What are clinical implications of all of this? What are our approaches to the inhibition of drivers of dysbiosis, aka risk management, or prevention if possible? I think that is in the future. Personalized approach to caries risk management at USC. What do we do in our school, in the clinic, with students, for patients? I'm going to talk about the in-house, in-clinic approach, and I also think universities are very important in shaping up the community-based oral health management and advocacy. So we also have some mobile clinics that deliver on that purpose for our community, and role of the universities is very important here to emphasize, because not every patient has the same access to care, and those are mostly vulnerable populations that suffer from diseases most of the time. So we have to give back, we have to support and advocate for policies on a government basis in our countries and communities. So and lastly, what do we come up with on caries prevention in pandemic time? So the next slide is going to be the fullest and one of the most important slides of this presentation, because it kind of summarizes it all. What do we talk about when we talk about oral microbiome? First of all, we know very well that since the results of human genome projects were published and released in 2003, we are evidently clear that we are composed, more of 50% of our composition is composed of microbiota. And when we say microbiota, microbiome, what do we mean? We mean microorganisms. We don't call all of them pathogens. So microorganisms, bacteria, viruses, fungi, parasites, you name it. But here on this slide, we can see the members of oral microbiome, and they have interdependencies. They are interdependent in health and disease. And in health, they form a stable biofilm. And then when the balance shifts to one of dysbiosis directions, and it's usually as a result of presence of either increased sugar and in the environment as a result of lifestyle and nutrition and oral hygiene habits all together. But the result is low pH and increase in sugar content. And on the other side, some changes in host defense, some modulations and propagation of inflammation. We either see dental caries or periodontal disease. And we have some members here, some names of microorganisms. And I would hate those slides when I was a student. But then later I fell in love, because you, my students, you want to very well fall in love with all of those fundamentals. These are going to help you make your decisions when you need to act fast and when you need to come up with inventions. And maybe you're going to be one of them. One of them. I'm going to be talking about the future too. So here we said once the balance shifts as a result of acid production or polysaccharide production, as a result of immune subversion or cytotoxins being produced, when the balance shifts, we have a predominance of one group of these microorganisms over the other. We have a shift in the biofilm, and we have shift towards dysbiosis. So when we talk about symbiosis, we talk about maintenance of oral health. So all of those microorganisms, they live together, they feed their presence. We have their contribution in metabolization of our nutrients, in stimulation of our host defenses, and downregulation of pro-inflammatory responses. So we maintain oral health. We are in symbiosis. But once the balance shifts as a result of our lifestyle change or changes in our health or our inflammatory response, so it's two things. Either we address nutrition and lifestyle, or we address in a holistic basis, we address our immune response and our health status. And that's how we keep saying oral health and our overall health, they are very, very tightly related on the biological basis because they affect one another interchangeably. So we have to address, as dentists, we have to wear 3 hats. We have to have our behavioral aspect of addressing the patient, and we're going to see why. We have to have our medical aspect of addressing the case, and it's very clear why. And then we will take our dental approach of our management and treatment. So what are drivers of dysbiosis? So inappropriate diet, inadequate plaque control, impaired saliva flow, lifestyle risk factors, broad spectrum antibiotics use. This is the simplified version of our understanding. So these are what we directly address to change, to shift the balance. And so as a result of all of those, we see inflammation, we see modification in host defenses, we see low pH, and then we see shift in the biofilm. We have to address the factors that lead to those shifts. So what are our approaches? Well, mainly we go for inhibition of acid production. So we use fluoride, we use metals, salts. We address and we aim for salivary flow stimulation. We use sugar substitutes, xylitol candies, sugar-free gum. We approach through restriction of acid production. So again, sugar substitutes. We have to address the diet. We have to have nutrition, conversation about nutrition and dietary advice. Here, we have to have a motivational interview. Our approach should be aiming for maximum compliance. So we have to connect with the patient. While we have that conversation, it is very important to know that for patient to stick to our advices, we need to have had connected with the patient and have had inspired the patient. And then lastly, we use pH rice supplements sometimes. So what are our fundamental terms here? Prevention, we said, is only pure prevention. Pure prevention is only possible if you address every single factor, including genetics, which we're going to talk about. So in this case, unless we address that, we're talking about risk management of the disease. So we're mostly talking about caries risk management here, intending prevention. Treatment we talk about when we are including all of this in our aspect, but in the past, in the very past, we were talking about surgical models, so mostly surgical interventions, restorative interventions, we mean, so which is restorations, silence, and medical model is more about considering the inhabitants and the host defense and the systemic health and having antimicrobial elements in our risk management. Personalized model talks about what is specific to that specific patient. How do I approach his particular lifestyle? How do I approach his content of his nutrition? And how do I address it in his particular personality type? That's why we talk about the behavioral aspect, the medical aspect, and the dental treatment planning overall together, because they cannot be separated. They have to be integrated together with the basic sciences, which shape our understanding of the nature of diseases and overall health. What do we apply in the clinic for our patients to be more, to have more personalized approach in our caries risk management? We utilize Canberra protocol, which is standing for caries risk management by risk assessment. So we assess the risk of every patient. We categorize them based on a specific risk group, and then we tailor a specific caries risk management protocol based on their lifestyle, based on their medical health status, and based on their caries risk. We utilize chemical therapy, antimicrobial therapy, which is mainly composed of prescription grade fluoride paste for high and extreme risk groups, and mainly behavioral change. We address eating habits, we address oral hygiene habits. So this approach, we believe, is evidence-based and gives us personalized perspective, and is based on the personalized caries risk of each patient. And there are studies done. There's a lot of publications on Canberra. We specifically do this. I want to explain it more practically. Wanted to put our form here. Patient is filling this caries risk assessment form, which addresses three main components of this process: disease indicators, biological risk factors. So disease indicators, we here we record, and you cannot read it, but in disease indicators, we are following up with cavities, white spot lesions, non-cavitated lesions, and existing restorations, and then we kind of assess the disease indicators in the first column. Then we also assess biological risk factors, which are the plaque. We address a frequent snacking, whether or not patient is using hyposalivatory medications, is there reduction of salivary function, any systemic condition on any medication that can lead to that. And also we do saliva function tests with our students. We measure salivary rate, and we also do saliva test, pH test for patients. We have those on site. They are practical. Then some of the biological or environmental risk factors here is recreational drug use, exposed tooth roots or orthodontic appliances. Once we address disease indicators and biological risk factors, we also look at protective factors, which is whether or not this individual is in an area where there is fluoridated water, is fluoride containing toothpaste used, how frequent, and are they being applied fluoride varnish once a 6 months, So what is the content of the fluoride of their daily use of toothpaste? And then we look at the balance, whether or not the balance is shifted towards the left side or the right side. So the balance, if the balance shifts towards, of course, the left side, we're talking about extreme and the high risk category. And whether or not the balance shifts to the right side, if it shifts to the right side, we talk about moderate or low risk. So here, the purpose is to classify the patient in a personalized manner. So our prescription of protocol, our approach, so carries self-management menu options here for the patient will be based on whichever category the patient is. If the patient is in extreme and high risk, we include chemical therapy, antimicrobial therapy, prescription grade fluoride toothpaste, and also we use antibacterial mouth rinse 0.12 chlorhexidine. For moderate and low risk, we mainly emphasize lifestyle changes, and also we talk about, in detail, we talk about sugar control options, oral health lifestyle reinforcements. We talk about all of those 4 categories with the patient before they leave. And this is their form. So here, your ability to connect with the patient is very important. Your ability to simplify, to lift them up, to inspire them will actually determine how, it's going to be very important in how compliant the patient will be. So protective factors, we address what kind of toothpaste is used, what kind of rinse is used, how is the water in their area. So are we going to use special products? So this is our kit, Canberra kit for high risk and extreme risk patients. It includes prescription grade rinse, prescription grade toothpaste, and xylitol lozenges, and floss, and also toothbrush. But this is the chemical therapy, prescription grade chemical therapy is going to be only part of the high and extreme risk patients protocol. So on this form, this is for the patient. It's pretty much simplified here for them. They have chance to self-reflect on their habits and track themselves. So how much do they fulfill for what our target is? So we are following this protocol. We know and we try to choose an evidence-based and personalized approach in our treatments whenever we're approaching any disease relating to oral health. So in this case as well, we know this protocol and the studies were strongly predictive, but they're not deterministic. So can we guarantee that if the patient sticks to this protocol, they're not going to have new carious lesions? We cannot. And this is not intended to be prescriptive. When we look at the reimbursement side, ADA has procedural code for this, but not every insurance is reimbursing this time that is invested into the risk assessment and coming up with a personalized protocol. So why is this not deterministic? Because, well, we cannot say that this is personalized to the bone. When can we say that our approach is personalized to the bone? Is when we have really, really very much precise insight into the risk of that particular patient, holistically, overall. So including their genetics and epigenetics. When we're going to start to use precision diagnostics, point of care diagnostics, and this is the future. I'm very excited about salivary diagnostics personally and precision diagnostics. So they're going to help us achieve our best in risk management, possibly prevention. So what is our medical and personalized model about? We need to learn, we need to really know very well our microbiota, our microorganisms, and how they get together. If you realize I didn't split pathogens that are related to periodontitis and caries. They live all together. So we see our patients every 6 months, and we manage caries risk and periodontitis risk together. They are all together. So what do we come up for microbiome modification? Prebiotics, probiotics. Maybe we're going to have microchips in the future. We're going to test samples of saliva, and then we're going to scan the immune response modulation, and then we're going to scan the microbiomics. We're going to know more about specific pathogens and specific factors of each person. So maybe we're going to use different modes of gene editing and immunotherapy, and simply maybe we're going to have rinses for enhancement of saliva and host defenses. Who knows? But dentistry is going to change, and it's exciting. It's exciting. Pandemic is escalating those changes. And what about pandemic? Well, what is going to change, and what can help for our caries risk management in pandemic time? Well, teledentistry is already there. So we have active inclusion of patients in the process. We utilize questionnaires, and then we can utilize routine preventive care protocols, and we can use point of care testing when in the clinic, in dental clinic. So we have rapid COVID testing now. Utilization of imaging technology. I know that there is some planning on shifting the perspective. So now for nursing homes and for distant connection and practice with the patient. So when I say active inclusion, we can send oral cameras. They produced some for patient use with high resolution. So we can track risk and changes by the patient using the intraoral camera and broadcasting to our office. So we can utilize web access and distant communication to enhance connectivity and actively include the patient and still manage our risk, even in pandemic times. So thank you for your attention. That was basically what I was trying to convey.
It's okay. Thank you very much, Dr. Dinçer. It's a very informative lecture. Before we will go to the second lecture, I want to remind to the participants that we will take the questions at the end of the session. Now I want to introduce and I want to invite the second speaker of this session. She is Professor Kuzmina, is coming from Moscow State University of Medicine and Dentistry, and she is also the FBI National Liaison Officer for the Russian Dental Association. Her speech title is "Today: Caries Prevention Strategies among Children in Russia." Please, Professor Kuzmina, we are listening.
Hello, everyone. Just trying to start the presentation. So, hello everyone. So, first of all, it's a great pleasure for me to be invited to present at the conference in the lovely city of Istanbul. I would prefer to do it personally, but so the time is this year is special. So, I would like to share with you some prevention strategies and minimal invasive approach for dental caries management among children, what we apply in our country. So I will start with the normal procedure we have. And then we'll touch at the end what has been changed during the epidemic time. So just some few facts about Russia. We're a rather large country with a large population, with the variation of climate and fluoride in the water. Therefore, the preventive strategy would be different and depending on the area where we apply. But I will focus on some of them. So the dental health service for children is provided by the public and the private sector. Then you can get it free of charge in the public, and then it might you can get it in a private, which can be covered by private insurance or be self-financed. In order to plan the caries prevention strategies and to obtain the data on oral health status among the population, the National Oral Health Survey is performed in Russia every 10 years. And the results of this survey showed that the prevalence of caries in primary dentition is high, and however, the prevalence of caries experience in permanent dentition in children is moderate but increasing with age. So there is a higher caries experience in the areas with the low fluoride areas, and there is no difference between rural and urban. So the slow progression rate of caries among the population offers us the possibility to implement prevention program at different level. So we can start with the community programs based on fluoride use, then it gives us time to go deeper and to implement the individualized caries prevention program for further decreasing of caries. So there were a number of different projects started in the country. But I would like to pay attention to individualized caries prevention programs, and some of them, they were based on non-operative caries treatment. So, and one of the examples is a preventive program which was based on Nexo method, and to implement this program, we provide an epidemiological study among children in Moscow. With the diagnosis of all stages of caries, including initial, inactive, and arrested stages. Then the results show that the highest caries prevalence was observed during the eruption period of the first and second permanent molar, and the first permanent molar, particularly its occlusal surface, accumulated the most of the caries experience in the oral cavity. So the program was started in 1994, quite a long time ago, and then two groups of children aged 6 and 11 were involved in the program just before the eruption of their first and second permanent molars, and then they followed for 2.5 years of this program, and after 18 years of program initiation, they were called back to see if there was an influence on the program in the long-term results. So the program was based on intensive education of parents and patients in mechanism of caries development, training them in toothbrushing, and attention was paid to erupting molars, and specially designed toothbrushing technique was applied. So professional tooth cleaning at individually planned recall intervals, and local fluoride and sealant application, all based on risk assessment. So intervals were based on, between the appointments, were based on cooperation or with child or parent, presence of active lesions on erupting teeth, caries experience, plaque accumulation, and stage of eruption of teeth. So the results of this program show that focusing on the risk period of the eruption of permanent teeth, there was a reduction of initial lesions in both groups. In some way, it was caused by arresting of these lesions, and there was an increase of number of cavities in enamel, However, it was significantly lower in the study group compared to the control group, and the same tendency was observed for dentin lesions. So the mean value of DMFS was significantly lower in the study group compared to the control group. So based on the results of this program and on other newly developed strategies, the algorithm of individually based caries prevention program was. So how we use it in the clinic? So the first step is in the clinic is meeting all the patients, and we pay a lot of attention to, especially with the children. We can face with the emotions like it's doubt or unwillingness, and then we have to interest the child and make him trust and ready for cooperation. And each book brings some messages, like A Healthy Mouth was published together with our German colleagues, and it draws children attention to the animal teeth. And then another book brings some messages for establish daily oral health behavior, like in the story it tells that you have to brush your teeth before breakfast, use a precise amount of toothpaste, reduce the frequency of sugar consumption. So brush your teeth before sweet parties and before bedtime, and then followed by advices to parents. Another book brings a message, and it tells a story about a microbe, but here we educate child in mechanisms of caries development. So, and we tell there is a bacterium on your teeth and can be easily removed by brushing the teeth, but otherwise it can go deep in the tooth, and then brush doesn't reach it, then you have to go to the dentist to take him away. And we also prepare child for the treatment in that case. Then on the next step, we identify the risk factors like a plaque, gingival status, and stage of eruption. So we use a different plaque disclosing agent and also visual plaque assessment. And then we use it as for identifying the activity of initial lesions, and at the same time for demonstrating the plaque to our dentist. So then it followed by supervised toothbrushing, performed by dental hygienist, professional plaque removal. After that, we perform the caries diagnosis, diagnosing all stages of caries from initial up to deep into the dentin, and assessing the factors influencing on caries activity. Then at the end of the appointment, and based on the risk factors which were observed in this patient, we plan the individually planned recall interval. And besides this, we also call our patient to visit dentist according to punctually applied caries prevention strategy, which was proposed by Kim Ekstrand. And it's based on the dental age risk period due to eruption of the teeth. And then we ask the child to come in these points, like a first primary tooth erupting, second primary, and establishing contact between teeth, and then follow the same principles for the permanent dentition. So here's the whole scheme of the punctually applied caries prevention strategies we apply for the young children. So the first time we ask child to come just before interruption of their first primary tooth, and then in that point we give an advice to parents, and we educate them in a toothbrushing and prepare them to brush their child's tooth with the fluoride-containing toothpaste when it appears. And then we allocate the child into the risk or no risk group. And at that point, it's based on mother's oral health status. And then we see both risk and non-risk group at the age of 16 months, just when first primary molar appeared. And then we continue with the advice and brief examination. In that stage, we use a fluoride varnish in when we see the signs of the initial lesions, and then again we do the risk assessment, and we see both risk and non-risk groups of children when the second molar erupted, and then we repeat the same procedure. And ended up at the end, at the age of 3 years old. And at that point, we examined these children by using ACTA. And then we applied this program in Moscow. And the results of this program show that it was effective in reducing plaque accumulation and preventing caries, particularly to the stage where operative intervention is necessary. But of course, it requires more short visits than in the control group. The results of the program also showed improvement in parents' oral health knowledge by the end of the program. Concerning minimal invasive approach in treatment of caries lesions, so we actually use the same steps when we do the caries risk assessment and diagnosis by using ICDAS and activity status. And then beside the prevention procedures and follow-up visits, we choose which minimal invasive treatment we're gonna use, in particular in this patient. And then for non-cavitated lesions, we can use some non-operative caries treatment like a biofilm control and fluoride-containing products. And for cavitated lesions, we can choose some of the procedures proposed for minimal invasive treatment. Well, and coming to the pandemic time we are now. So how we have to adapt our prevention strategy. So we would prefer to continue it by using the same principles. Of course, we have to focus on the protection equipment, on the disinfection control. We have to plan a longer treatment time. And then we temporarily, I hope, have to modify risk assessment by planning a longer interval between visits. We try to apply minimal invasive techniques, trying to reduce aerosol producing the use of aerosol producing equipment. Then there is also, we have to also adapt communication with our children, because normally we had a procedure like we have it on the left side of the slide, where when we play, when we smile, and we don't keep a distance. But of course, now the way how we look, it has changed. So, and then our children, they see us in another way, in all this equipment, and the only what is left for them, it's the same drawing on the ceiling. But then we have to change the procedure. What we do, we meet the child in the lobby, and then we say that we are going to put some protection, then to prepare a child that he will see us in a bit different view. But surprisingly, children are not scared, and we try to smile through all this protection. But then I think they appreciate it, and I think it's important when you smile by heart, not only by face, and then it works. And moving to the end, when we plan the preventive strategies in pandemic time, of course, we have to estimate the specificity of the country, what is the disease level, what is the severity of cases, is the PPE available, and of course we have to pay attention to infection control. It's discussed a lot what is non-essential or non-urgent treatment, which are allowed to do in the specific periods now. And I would say that to keep the same principles of prevention, of risk assessment, we have to find some balance between the risk of caries progression and restrictions for dental clinics due to infection risk. Then I still hope that it is temporary. So then at the end, I would like to thank for your attention. I would like to thank organizing committee of the conference, and I would like to send my personal appreciation to Funda Yankuglu. Thank you very much.
Thank you so much, Professor Kuzmina, to share your data from your country and from your research. Now we are going to the last speaker, our last speaker. She's coming from Holland, from ACTA, Professor Monique van der Veen. She will, her speak title is Plaque-Related Diseases from Treating Symptoms to Maintaining Health. Please.
Thank you. I hope that people can see my screen, because I was already sharing it, but I still see this. Let's go back and share my screen again. Okay, somehow I do not see my screen. Is there any backup plan for this? Because I'm sharing the screen. I do not see the screen share in the chat, so do people see my screen?
We cannot see your screen.
Yes, but I am sharing the screen, so I do not know. Now it's coming.
Okay, okay, now it's come.
Yes. So thank you very much for inviting me today. My name is Monique van der Veen. I'm from the Department of Preventive Dentistry at the Academic Center for Dentistry in Amsterdam, ACTA. And I'm going to talk to you about plaque-related diseases, from treating symptoms to maintaining oral health. Now, over the past decades, there has been a paradigm shift in dentistry from restorative care or cure towards preventive care. And as part of this movement, since the 1980s, dental research has focused on new detection criteria, such as ICDAS, and methods to detect caries at earlier stages, such as diagnodent, QLF, DIFOT, ECM, or techniques using ultrasound. These techniques allow secondary prevention, leading to caries arrest. But despite their success, they still do not allow true primary prevention. So it is time that in the 21st century, we move towards health promotion. We need to be able to assess precursors of disease symptoms in individuals who are clinically not still healthy, so they show no signs of oral disease. But how do we define oral health? Oral health is a multifaceted and includes the ability to speak, smile, smell, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, and disease of the craniofacial complex. But in the context of this talk, let us focus on the healthy oral cavity as having no caries, no gingivitis, no erosion, no periodontitis, no mucositis, and no halitosis. So part of the answer may lie in the assessment of the quality of oral plaque and saliva. As is well known, bacteria, the main microbes in oral plaque, play an important role in the development of caries and periodontal diseases. Under healthy conditions, these bacteria are commensals to the oral cavity. They only become pathogenic when a disturbance drives the oral microbiome towards a disbalance. Key to preventing disease would be the understanding of how and when such disbalance occurs, long before any symptoms of the disease can be observed in the oral cavity. And such assessments would benefit from chairside tools, allowing the assessment of changes in plaque, because most of the microbiological techniques that we are using these days, like qPCR or sequencing, are not instantaneous. They do not provide an answer real time. So when, as I said, oral diseases are basically ecological catastrophes. So when we are in an ecological balance, we look at a healthy dentition. But once we change our diet to a more carbohydrate-containing one, we see a shift in the microbiome towards dysbiosis. It's more saccharolytic and acidophilic community, leading to caries. If, on the other hand, we are our immune system is lacking because we have not brushed well for a while, we may drive the microbiome towards a more proteolytic, alkalophilic community, leading to eventually gingivitis and periodontitis. So we had a look at healthy individuals because for the past generations we've been looking at clinical manifestations of disease, symptoms of disease, being capable of trying to arrest those situations, but we would like to aim at modifying health towards an even healthier situation. So in the study that we performed, of which I present the article here, we were looking at the microbiome and metabolome in the saliva in individuals that were healthy, clinically healthy, both systemically as well as in their oral cavity. And we took their unstimulated saliva after overnight fasting and 24 hours since the last oral hygiene procedure. What we were looking at in this study, our study aim was to describe the boundaries of and the heterogeneity within the healthy ecosystem to decipher the relations between salivary bacterial composition, the microbiome, salivary metabolites, the metabolome, and the host-related biochemical salivary parameters, as well as diet. And what we found were 5 ecological different groups, as can be seen here in the upper left corner on the microbiome samples. Now, when we look at one of those groups, we can notice whether they are shifted towards more saccharolytic or proteolytic disbalance. In saccharolytic groups, we would see more lipid degradation, Streptococcus mitis, salivarius, vestibularis, and towards the proteolytic groups, we would notice the more periodontally related bacteria. We could also notice whether people were still more or less adaptive, as in having still a resilient microbiome or immune system, or a less resilient microbiome and immune system, driving towards early dysbiosis, so the microbiome already being more specialized. And that would be visualized by finding a lower resting pH in the saliva and a lower diversity of the microbiome, whereas on the proteolytic side we would find high albumin, high resting pH, low lysozymes, high chitinase, and a high ecological complexity. So 5 oral ecotypes, yet these ecotypes were considered to be clinically healthy in their oral cavity. And that implies that one size of preventive care does not fit all. We need a tailored oral care according to people's ecotypes. And we must realize that the most specialized ecotypes in this sample, even though they were clinically healthy, could already be more susceptible towards disease and could indicate a disturbed ecosystem at a preclinical level. As mentioned before, studying the microbiome and metabolome is not really an instantaneous technique. You have to be patient and wait for the outcome. So we have chairside techniques that help us visualize what we can find in detail in the microbiome, but in an instantaneous picture using QLF. And we studied a subsample of the group further in a kinetic experiment. So we ran an experimental gingivitis study, basically trying to see if there were differences in resilience within the group. And what we noticed during this gingivitis study, we studied them from baseline where they were still brushing, followed them throughout 14 days of no oral hygiene, and then last but not least, a recovery period of 7 days. And we studied several things, such as the clinical indices, the red fluorescence, which we took with the camera you just saw on the previous slide. We studied the microbiome, metabolome, and so forth. And we did that in time before, during, and after the gingivitis experiment. So let's focus on the clinical indices, the red fluorescence especially, and the microbiome. These are 3 typical examples from that experiment, showing a low, moderate, and high response in red fluorescence. And you can already see the differences at day 1. Individual A is from the low response group, B from the moderate response group, and C from the high response group. And the low, moderate, and high response group were statistically significantly different at all time points through the study already at baseline, as you can see here, because clearly in the top left image, you see hardly any red fluorescence, whereas in the middle image, you can clearly see some red fluorescence, especially here in the lower front area and here in the back. Whereas in individual C, you see red fluorescence upper as well as in the lower jaw, quite clearly. And when we go to day 5 of not brushing, you see that the differences have become more pronounced. And towards day 9, they really stand out and they are clearly very, very different. What is important that throughout the study, the amount of red fluorescence increases in time during the period of not brushing and returned to baseline level after 7 days recovery. But also that we can separate these 3 groups at all time points statistically already from baseline. Now let's have a look at the individuals and the change in red fluorescence. So these are all the individuals that we studied and followed in time. And this is how they responded with gingival bleeding, and it's a markedly similar pattern. The location of the individuals on the x-axis is the same. And this is the response of the plaque composition. Now, to me, these patterns look very, very similar. And like with the QLF images, we could separate the 3 groups. With studying the microbiome, we can clearly separate the low response group versus the high response groups, explaining about 17% of the variance along the x-axis. And maybe more important to you clinicians is that the red fluorescent plaque from day 2 of the experimental period correlated significantly with the bleeding score that we found after 14 days of not brushing. So already after 2 days of not brushing, we could predict how severely the gingivitis was that they developed after 14 days of not brushing. So we were able to give a slight prediction about their resilience. So basically what we see here is we have groups of people who are all clinically healthy at baseline. We give them stress, the same perturbation, but resulting in very different outcomes, implying a difference in resilience. So that's where we need to target our research, looking much more into the role of the host ecotype in resilience to stress. One-size prevention does not fit it all. So that's our challenge for the future. We need to identify the right individuals for the right preventive strategy. Thank you.
Thank you so much. Nice presentation, for your nice presentation. So we are coming at the end of our sessions, but I understood once more that there is a strong relationship between general health and also oral health. So in this, especially in the during the pandemic time, we always remember these strong relationships. So the assessment of the caries and also the preventive applications are still very important, and minimal invasive treatment approach also still very is valuable. If the participants wants to ask some questions to the speakers, please don't hesitate to ask them. You can ask from the chat, and we can discuss about them. Is there any questions? It seems no questions, but we can, if you want, we can discuss. Okay. So, comments. Okay, I will look at the comments. Yeah. There is some questions. The first one: why are you using Cambra? How does this relate to the ICCMS that is currently promoted for caries management? From Veen to ask whom? To Dr. Dinçer. Is that right? Yeah.
Yes.
Can I repeat, or did you hear me, Dr. Dinçer?
Yes, yes, I hear you. I also look at the comments. So, oh, Monique, this is a question from Monique.
Yes.
So, could you, so like, why are we using Cambra? So first, so can you open it up a little bit?
Well, Cambra is, I think, from the 70s or 80s already. It's been a long time in use, and I think it's probably the best system out there still. But it's also very elaborate. It's very laborious to do it, and like the microbiome.
Laborious.
Well, there have been. It takes a lot of time to fill out the entire sheets, of course, and to and especially if you also want to analyze the microbiome along part of it. It's not instantaneous. So how are you going to deal with that? And there have been studies out there showing that when a dentist just uses their gut feeling in determining what the risk is,
no,
that seems to be equally well as using the Cambra system.
Well, we don't use our gut feeling. So the studies of the same group, they had been initiated long time ago, but then in 2018, 2019, there were new versions that are RCT trials, there were validation trials, so there is new publications. If you follow, there's practice-based network dentist practices results as well. So do we do microbiome analysis? Do you do microbiome analysis on a daily basis in school, in practice? We don't do either. Yes, we analyze risk factors. And then I particularly wanted to show our form utilizing Canberra, right? We utilize this specific practical form. When you say utilizing Canberra, and it is very old, so I didn't quite get what you are approaching, but we are following up with the latest results of RCTs and the practice-based results, and we have our unique form where we choose specific specific disease indicators and environmental risk factors and protective factors. So we frame it up. Microbiome testing is not there yet for any of us. This is the future, as I said. So the most practical, personalized, and as evidence-based as possible method is what we try to utilize, and we're not Canberra fans. We have our specific form where we can track the as objective as possible contributory factors from different perspectives, meaning that indicators in biological environmental risk factors and protective factors all together. And we train our students before they are in the clinic. So the timing and training happens before. We are all considering it all together with the behavioral aspect. So we have patient forms as well for the same purpose. The graphics are simplified and compliance is targeted too.
Okay. There are two questions from Funda Yanıkoğlu to Dr. Dinçer. What method do you use for the diagnosis, PCR or NGS system? And yes.
So in the clinic, we don't do microbiome testing yet. But so in my presentation, I was contemplating on the research that is going on right now to better understand the dysbiosis and symbiosis and the translation into the clinic. How can we use the most personalized and evidence-based, still translated clinical approach? And I contemplated to the future, PCR or NGC is not used in the clinic yet at USC.
Okay. And there is another question from Professor Van der Veen to Professor Kuzmina. Have you invested in extra outreach to families at home to keep up the oral hygiene and healthy diet during the pandemic?
Yeah, so actually we don't have any specific program now. During the pandemic, when we had this lockdown and when everybody was required to get home, the only what we had is there was some group of dentists from public clinics, and they came up to the families to do some urgent treatment. So that was the only. So what we also did, so we would have some like a phone or WhatsApp connection with our patients, but not specific program yet, because now all clinics are open. We really try to keep or follow all the requirements for due to restriction and disinfection. But then now people, they visit in clinic. So we try to extend this interval between the appointment a little bit, but not compromising too much with the caries risk. And when, for example, when after lockdown, when we open the clinics were open again, we tried to make an appointment like by one family. So we took half a day or several hours only for one family, just to avoid maybe extra contact, but not any specific yet.
Maybe. But did you notice any differences now during the pandemic with the oral hygiene levels in the children, or perhaps in how in the diet that people are using. Here in the Netherlands, we've executed some studies, and we noticed that while the schools were closed, the children would snack much more than they would normally do when they were going to school. So their regular daily rhythm was completely disturbed. They were snacking more. They were not just more, but also more sweets and more, very bad snacks for their oral cavity. And they did not need to brush their teeth early in the morning because they were not going to visit anyone, so they did not need to have a fresh mouth. Did you notice any of that in your study, in your population, now that you are opening the clinic again?
Sorry, I didn't hear the last sentence. Sorry, Monique.
But did you notice anything like that, like children eating more sugary snacks, drinking more lemonades, having a less regular daily rhythm while during the pandemic, as in during lockdown, than before?
So we did not notice any change with our patients, but I believe there are some changes, and maybe we have to learn it, to examine, because what I know that maybe not in the toothbrushing habits, because they still have these lessons, they're online, but I think there will be change in dietary habits, because they're snacking all the time, sitting with the computer, having some sweet stuff or a piece of bread. I'm sure that there will be some differences. Maybe we will do it.
Yeah, maybe it's good to have some outreach program, as in online, I don't know, games for the children where they are actually playing with brushing their teeth, getting brushing instructions, and targeting eating a healthy food together with their parents.
Yeah, might be it's a great idea. The only what might be barrier for this, that parents are so tired that children, they spend a lot of time by the computer. So they, from early morning till late evening, even inside some schools, the vacations are like canceled, because they think that people are at home, so they can just continue study. So they spend a lot of time by the screen. But the idea is perfect. So we have to find a way, maybe by short movies or by brochures.
Mm-hmm.
Yeah, that's great. But I still hope that the situation will be better. I wish it. Maybe it's too optimistic. I don't know.
Dr. Yildiz, we cannot hear you. Your microphone is mute.
Sorry. Okay, thank you very much. We have a last question from Funda Yanıkoğlu to Professor Kuzmina. She's asking that she's saying that it's a so good program you did. If you could repeat it, what would you change or add about your study? I think so. The methodology.
Yeah,
maybe.
Thank you. Actually, we use this program, and we use the principles which we're using for at least 18 years, because we know that it's effective for our population, but we always change it, and we always add some of the steps according to new research or to new findings. Maybe we can continue, of course, we can continue to work on risk assessment, and we might change or might add some of risk assessment requirements or measures. Yeah, but then by now we just go on with this program, and of course we adapt it to the population. And then we use this individual-based approach, at least as much as we can do it. Not for the larger group, but actually we have a clinics everywhere, so it's available. All families can come for prevention as well. So sometimes it's a question of motivation, but the population is very, I think it's highly motivated in respect of their children. So because with the children, they're very organized, they come at the appointment, you stay with the, for themselves, for the adults, they can skip an appointment, but for the children, I think it's some kind in the culture that they try to really do their best. Yeah, but then we will continue to improve all the time.
Okay. Okay. Thank you so much. I think that we have to close the session. I would like to thank you for attending the session and for your valuable lectures. I hope to see in another scientific platform also. See you later and healthy days. I wish you healthy days and see you later in another time.
Okay, thank you.
Thank you. Thank you.
Thank you.